must know NCLEX pediatric GI topics. Expect to get a question on any of the images you see right now. So we'll get to it, and I can give you some of the testable information that you didn't know and have it at the back of your head in case you see a question like that. Um, the first one we'll talk about is esophageal atresia and tracheoesophageal fistula. Basically, this is both an airway problem and a GI problem, and so usually you have the trachea like that, which evolve in the airway. It branches into the bronchiole, and your lungs are here like that. These bronchioles, and this is the trachea, and esophagus is behind it. So I'll use another color. Esophagus is behind it like that. It come, and then it go into the stomach by passing through the diaphragm and the rest of your intestine. And so this is the esophagus. And this is the trachea. So that's your airway here, and digestive system is here. Unfortunately, sometimes things happen. This usually doesn't occur. Okay, so you have the trachea still there, okay, right? The esophagus is not continuous. You have a pouch like that, and then the distal portion go and still go into the stomach. And so this is what we have. This is the trachea. This is what we call esophageal atresia, the EA. And then there's a connection between the two. The distal portion, you have the distal portion, there's a fistula between this. That means there's a connection between the distal portion of the esophagus and the trachea. So you can see that what is going to happen to this patient? Well, there is no connection between the upper esophagus and the lower esophagus. So saliva, they can't swallow. When they try to eat, it just go to the upper portion of the esophagus and stay there. And sometimes the food can go into the trachea and they will be choking. So it's an airway issue. And so this is this is what we mean esophageal atresia, tracheoesophageal fistula. So based on the anatomy, the pathophysiology, you can make up any question, any idea what they're going to ask you. You can figure it out. Like this is the most common. There's almost about 4 or 5 types of the atresia, but this is the most common one you see. And it's found in newborn. So this is a newborn baby. Early, as soon as they born, they in the NICU, they can find it, and they can find it. So what do you think the patient is going to present? Well, presentation. The first thing they will figure out is they try to pass NG tube inside the esophagus. It will coil in the chest and it will not go. So coiling of NG tube in the chest, because when the kid is born, they will have a respiratory distress and they will try to put the NG tube to suck the stomach, but then it will coil in their mouth multiple times and they will figure out why is it not going. They'll get an X-ray and they see that the NG tube is in the chest. And so coiling of the NG tube is what you see. The kid cannot swallow is their saliva. So you see like excessive salivation. So you see fruity saliva non-stop. And what do you think? If they can't control their saliva, well, it will make its way into the trachea and they will be choking. This is the same. Sometimes it won't present like that. If the kid is eating, they will have choking. So also choking with feeding. They will figure out when you feed a kid, because he's staying in the esophagus, then it reflux back into the trachea because the esophagus doesn't connect. So nothing go into the stomach. And so they will have choking with feeding. Okay, that's one of the signs they may ask you. So this is the number 1 sign choking with feeding, that's a clue that is something is not right. Because they cannot control their saliva, they will be drooling. That's another symptoms you should see. And they will be coughing excessively because they are aspirating, coughing too much. If you feed them and they choke, you see cyanosis. So cyanosis with feeding. And so that's what happened. So you can see that all this is like airway issue. This patient is number one is airway, and that's a priority observation. A B sharp thing, that B sharp issue you should be worried of. B sharp is an airway, major airway issue with this patient. They will have air going to their stomach, so the stomach will be distended. Okay. And so this is how they present the tracheoesophageal fistula, the NG tube coiling, a lot of saliva, choking, which is the priority, and drooling, coughing, cyanosis when they're feeding. So what do you do next? Well, you want to prevent aspiration. So prevent aspiration is your number one. Okay, number one function as the nurse, prevent aspiration. How do you do that? Well, make them MPO so that they cannot eat. They will need an IV fluid to hydrate themselves. Okay, and that prevent aspiration because of the choking. And most of this will need time for surgery. You give some time for surgery. So they will need the connection to be repaired and fix it. So that's all the most important information I provided in your question. They will say priority finding for esophageal fistula, look for airway answers. So airway. And if you look for my B sharp airway, they can be restless. They can't control their saliva. Okay. They will be choking and they will be drooling. These are all clues that they're having airway issue. These are your priority intervention where they ask you a choice. This is what you choose: airway, airway, airway for these patients. The next one is Hirschsprung. So if this is the stomach, okay, coming and you have your small bowel coming like that, you go into the appendix, then the colon, transverse colon to the descending colon and the sigmoid before you go into the rectum. Okay. In the rectum, there is sphincters here. Okay. But this muscle, this colon has ganglion. So there is cells that nerves that go into the wall, mostly acetylcholine ganglionic cells. And it causes the bowel to contract. That's how we're able to evacuate, have bowel movement, for the peristalsis and everything. Patients with Hirschsprung, they don't have these nerves. So these nerves that go there to make the rectum, lower portion of the rectum or whatever portion of the gut cannot contract. So what happened in this segment of the bowel, you have the descending colon coming out. And when you get to the rectum, because there's too much pressure here, the rectum get dilated like that. So this become a very big, like a big, very big figure basically. So there's too much constriction, obstruction here from the sphincter. And so this get dilated. So the whole, this doesn't work. So it's due to lack of ganglionic cells. And then the sphincters, okay, internal sphincters of the rectum, they don't work at all. Because of that, the proximal bowel has to get dilated. So they usually distended. This patient, their bowel is distended. And then since this, the sphincters cannot relax, nothing can pass through, nothing can pass. They cannot evacuate. So when the kid is born, within 24 to 48 hours, there's no meconium. So it has not passed meconium. They can't pass meconium 24 to 48 hours. That's when you will know, because their sphincters cannot relax and their belly is distended and they're full with poop. So too much stool in their belly. They have to evacuate. So where would it come out? If it's not coming out from here, well, it come out from the top then. So they're going to vomit. Okay, so they will vomit it out. They will vomit. And when they vomit, it's going to bar. There will be bile in it. So bilious emesis. And so these patients, the treatment is going to be the same. They have to be MPO. They will need an IV fluid to hydrate them because they get distended. They will need some nutrition. Okay, they can't eat. So they will need some nutrition and prepare them for surgery. So they are MPO, IV fluids, some nutrition, either TPN, and prepare them for surgery. But in your question, in your answer, in your test, they may want you to identify that this patient cannot pass meconium in 24 to 48 hours. That's a sign of a Hirschsprung disease. And then in the SATA question, it may be they will give you distended abdomen. So they'll give you something consistent with the problem. So distended abdomen, they will not pass meconium, like I said, and then they will have emesis, which is bilious. And so those are classic. And then their sphincters, internal sphincters, doesn't relax. There's not too much you guys need to know. I mean, the treatment is they will need surgery to give them colostomy. I don't think they will worry you guys the details too much. But basically, just to be familiar with them, what it is, Hirschsprung, lack of realization of the sphincters due to the lack of ganglionic cell. So the bowel is dilated, they vomit biliously, and then they don't pass meconium in 24 to 48 hours. That's all on Hirschsprung. You don't need to know anything about it except what I've provided. The next one is, I think, maybe their favorite because is we see it, or you can confuse it with a bunch of issues. So this is the stomach again. This is the this is the esophagus, okay, and this is the stomach. And the first portion of the stomach coming down into the small bowel before you get to the duodenum. This is what we call pyloric. So there's like a sphincter here, prevent food from refluxing. The same thing, there's a sphincter here. So usually, if you eat, stay in the stomach, you chime it, then you go down through the pylorus. So you go into the pylorus, down into the small bowel. Well, these people, the pylorus is too thick. Okay, so it's still thick, so things cannot pass through. So that's why the name is called hypertrophic pyloric stenosis. Okay, hypertrophic pyloric stenosis. So the name and the pathophysiology is coming from this. There's few things you have to know. Okay, we don't know what causes it, so it's unclear. Well, etiology is unclear. Usually, it's the firstborn. If it's going to happen, it's going to be firstborn baby that is born will have this disease. Okay, and it occur early, so you can figure out 3 to 5 weeks after birth. Because kids vomit all the time. Oh, okay. When you feed them, they may have some burp and they will vomit a little bit. But this one is different. This pyloric stenosis is completely different. It's not just a simple vomit. These people, they have what we call postprandial emesis. Postprandial. That means after feeding. After you feed them, okay, they don't just vomit. Postprandial emesis. After you feed them, it's postprandial. After you feed them, they will have like what we call projectile vomit. So they will just vomit like really projectile. It can go far away, like 3 feet away. I mean, projectile vomit. But because of the where the obstruction is, what do you think? Bowel is usually in the small bowel, and there's obstruction here. And food has not make its way into the small bowel. So the emesis is non-bilious. So that's very important because that's how you can distinguish non-bilious emesis. So when they vomit pyloric stenosis, there is no bile, it's not green. It may be just gastric content. So whatever they eat, if the milk they eat is all the milk is coming out because the milk has not make its way out. So they will vomit everything out. So it's the emesis is non-bilious. What do you think? If you eat and then you vomit all the food you eat, what will happen? Well, they're hungry all the time. They want to eat all the time. So they're very hungry constantly, non-stop. They're very hungry constantly. Despite that they've fed, the anger is not due to the fact that they want to eat food. The anger is because the food that they eat was completely they don't absorb it everything. So they vomit everything out. And so those are the clue that you will know this is just the pathophysiological diagnosis of that problem. Postprandial emesis is non-bilious, and then usually after they eat. On physical exams, when you examine them as a nurse, there's some classic things they may ask you. I don't know how important is it. So you have olive shape because of the mass here. This mass here, it feel like olive shape because the kid does usually don't have it. You can see through the abdominal wall. The abdominal wall is thin, they're skinny, so you can see you can palpate it to olive shape mass. You feel like a mass. It's palpable mass. It's right in the middle so it's the mid epigastric. So mid epigastric and or on the right side of the umbilicus. So olive shaped mass in the mid abdomen towards the right a little bit because of the way the pyloric make its way. It tends, you see, it tends this way like that. So this is your left side and this is your right. So that's why you can feel it crossing the midline towards the right of the belly button. Yeah, so you see it on the right side of the belly button at the mid epigastric. These are physical finding. I mean, they may put it there in your questions just to make a diagnosis or start a question, but you have to know this is the classic on physical exams. This is what usually you see. So olive-shaped mass at the mid epigastric, right of the umbilicus. I think the most important is what you see, okay? Because they're coming to you, well, if I see olive shape mass, it's not important, right? If I see projectile vomiting, it's what is happening to the kid. Or, and this is very important that they can ask you. Anybody who is vomiting, it's a problem. So what do you vomit? So this is your stomach. Your stomach is made up of acid. And you usually, when they vomit, they're vomiting salt, sodium chloride. So they're losing sodium, they're losing chloride, and the acid in it is going. So look at what they're doing. They're losing all this. So all these people, they have lost all this. What does that represent? Whenever you lose sodium, you've lost water. So they've lost a lot of water. And so what do you think will happen to them? Well, dehydration is the number one. This kid eat and they vomit everything out. So dehydration is the number one priority. So this patient, they really dehydrated, really bad. And the body is in the state where it want to bring the dehydration down. So this is a priority finding. When you see this, this is B sharp. You B sharp hypotension. So it's in the shock state. So they'll go into hypovolemic shock. So the priority finding for patient with pyloric stenosis is dehydration. And how would the dehydration present? Because that's what the examiners, they want you to know if you understand what dehydration means. They won't say dehydration. They're going to have dry mucous membrane. Okay, their skin will be dry, right? Really dry skin. Okay, and then what would you see when you do lab work? Well, they will look dehydrated, so the hematocrit will be hemoconcentrated. Their RBC will also go up. And what is the common lab work that shows that you dehydrated, where your kidney function doesn't like it? Your creatinine goes up. Okay, your BUN also go up. So these are like SATA questions. Your GFR will go down. Glomerular filtration rate. So these patients, all their lab work shows evidence of dehydration, where their urine output is down. What do you think their urine specific gravity will be? Really concentrated. It will be really, really high. Okay, because they are reabsorbing most of the fluid. So they really dehydrated patient. That is their major problem. It's not because of olive shape um, and size. If you see that in the question, don't pick it. Okay, unless it's a SATA and to get a diagnosis to show that it's pyloric stenosis. But their major problem is dehydration. So your treatment is what? Well, give them the fluid. Give them fluid, 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 fluid. So IV fluid to stop the dehydration is very important. Okay, IV fluid is very important. But I'm going back to pathophysiology. They've lost all this sodium, chloride, and acid. So when you lose acid, what happened to you? You become alkalotic. But because you're losing true acid, it's not a respiratory issue. This is what? A metabolic problem because you're losing physical acid. So this is metabolic alkalosis. Therefore, you expect their pH to be greater, right? And greater than 7.5, right? It's greater than 7.5. So their pH shows alkalotic state. Now they've lost sodium. So they are hyponatremic. They've lost what? Chloride. They are hypochloremic. And the last one, which require a lot of discussion, you can look at my CHF this thing video where I talk about renin-angiotensin system. Well, if your body knows that you're losing potassium too much, you secrete aldosterone, and aldosterone go to the kidney. If this is the kidney, it tells the kidney, well, I need a lot of fluid, and the only way I get fluid is to hold on to sodium. So there's something we call sodium potassium channel. So sodium potassium channel. So in the kidney, you absorb all the sodium because you're vomiting them out. All this sodium in the urine is absorbed, and then what you get rid of is potassium. So you exchange potassium. So you pee out potassium and you pull sodium from the urine. So they become hypokalemic. So this is a classic metabolic that you should know. And you can say it become natural for you. You should say it because it's a classic lab work you should see in the lab work for patient with who is vomiting or has pyloric stenosis. That is metabolic hyponatremic, low sodium, hypochloremic, low chloride, hypokalemic, low potassium, metabolic alkalosis. And that's classic laboratory finding. So in a SATA question, sodium is low, potassium is low, chloride is low, their crate is high, show dehydration. So what do you think? If I have to treat this patient, I have to give him back everything they've lost. So the fluid you give them is a classic fluid. So the fluid. So treatment fluid, where give them is isotonic fluid. So they probably get sodium chloride, but they've lost potassium. So they may have maybe some potassium in it. So usually it will be like D5 normal saline plus chloride, maybe 20 milli equivalent of potassium chloride. So they need potassium chloride in addition to what they've lost. So that's the fluid they get. So sodium chloride, right, plus potassium chloride to help to prevent this problem. It's a cycle. If you don't control it, it will continue and continue and continue going. So that's the treatment. Isotonic fluid with some potassium. They will finally need surgery to open the stenosis. So that's the final treatment. Before I start talking about pyloric stenosis, it's very important to be able to know the difference that this is not normal burping. The kid is burping and vomiting after feeding. So you got to ask the mommy, how is he feeding? She has to describe the baby because they'll just tell you the baby is vomiting. So you got to figure out how are they feeding the baby, and then when do they baby vomit? Is it right away or how bad and usually every feeding do they have that, and the technique that the mother is using to feed the baby, you got to pay attention, you got to ask so that you can differentiate between the two. The next one is cystic fibrosis. Me personally, I think cystic fibrosis is also a GI pathology, pediatric GI, although there's a respiratory problem associated with it. So that's why I had it to that. Cystic fibrosis is a very interesting problem. This is a genetic problem that you inherit from your family, both parents. So this is papa and mama has to be affected for the child to also has the disease. If both mommy and papa has to have it, then this is a recessive, so autosomal recessive, because they both have to contribute it to for you to get it. So autosomal recessive. That means both parents has to be carriers. They are carriers. The problem is, you know, we make salt and then we have sodium chloride channels that help you absorb salt. Like I want to show you on the pyloric stenosis, you absorb salt and then water and get rid of potassium and other things. These people, they lack sodium chloride channel, especially chloride channel. So they're going to lose all their salt. They lose all salt. So because of that, this is all the pathophysiology. This is all you need to know, the pathophysiology. They can absorb salt, sodium chloride, because they have sodium chloride channel problem. So they're going to lose salt. So when they're sweating nonstop, so they sweating, perspiration, all is losing the salt from sweat. They can't absorb it back. Okay. And then because they're losing the salt and the water, where any secretion that they have is going to be thick. So every secretion will be thickened. This is where the problem is. So the lung is in trouble. The pancreas is in trouble. The GI tract, so the stool is in trouble, because these are all, you have some secretion. And if the secretion is thick, well, it's going to clog the lung. Secretion is thick, clog the pancreas. Secretion is thick, your stool clog you up. So that's, you see what I'm using? I'm just deducing. It become a problem, and now you can see the presentation, how they're going to present. Okay, they can present that way because this is the problem they're going to have. The pancreas is blocked, the stool is blocked, the lung is blocked. So all the secretion is a problem. So they can't get rid of their secretion. They can't get let the pancreas secrete their thing, and then you can't get rid of your stool. So it become a problem. Because of that, so your treatment, okay, is we start from losing salt. So you can break it down. Salt lost from sweat. Well, tell them, okay, to increase their salt intake. So increase salt intake because they're sweating everything out. If they can't absorb all the salt they sweat, then don't go out and sweat. So avoid extreme temperature. Like really, when it's hot outside, yeah, hot weather, just don't go there. And when it's hot outside, don't exercise because you're going to sweat everything out and you get dehydrated. So this is all related to dehydration. Day two, they have dehydration issue. So they can ask you questions relating to that because they're losing all their salts. So you teach them, okay? Their urine output will be dark because they're losing all the water and sweating. So avoid all. So that's your teaching and that's your management for this patient. Then let's go to the pancreas. Well, the pancreas too is in trouble. It can't secrete its content. The pancreas is very important. It secretes pancreatic enzymes. And this is involved with digestion and mostly fat digestion. Okay. So they cannot metabolize fat. If you can't metabolize fat, if you go to Walmart, McDonald's and go and buy some cheeseburger, well, what do you think will happen to them? Their fat will stay in their stool, and so their stool is very voluminous. So a lot of stool, and it's fatty. So fatty stool. Okay, they are fatty stool. We have to help them. They need the enzyme to be able to absorb fat, and so they need enzyme. So there's medication, the enzyme that they can give them exogenously. They take the pill like enzyme, like you take Tylenol. So there's a tablet for the enzyme they can take. But when do they take the medication? What do you think? Well, they take it when they're about to eat. So eating, even if they're taking snacks, they gotta take it. Whatever they're eating, they need the enzyme. But you have to take it if there's fat in it. If you're eating something, there's no fat, there's no need to take the enzyme. So they take the enzyme when they're eating fatty food. The other thing too is you also have to, they will lose some vitamins. So we have to give them this vitamin, EDK, vitamin EDK. If you don't know this, these are fat soluble vitamins. So fat soluble. So because they cannot absorb fat, they need these vitamins. You got to give them fat soluble vitamins. So they have to take it to help with that. Because they cannot absorb most of their fat, they'll lose, they underweight. I mean, and they're more nourished. So you have to give them, this is consciously as a nurse, they need a high calorie, a lot of calories and protein in their diet and fat. So high calorie, high protein, high fat diet so that they can grow. Otherwise, they won't grow. So this is you see teaching based on the pathophysiology that the pancreas cannot secrete its content. They need some enzymes. The stool is going to be fatty. They take the enzymes when they're about to eat. They need fat soluble vitamins, and you need to give them a lot of calories. So high protein, high fat, high calorie diet. So the next one is their lung. I told you it also affects the lung. They cannot get rid of their secretion. So you got to help them. Okay. You can give them something that will break the secretion. You can give them mucomist. So this help break down the secretion and they can get rid of it. You can also do chest physiotherapy to break down all the secretion so that they can put it out. But this is very important. You got to be, it's a testable point. So pay attention. Okay. When will you do chest physiotherapy? Well, 1 hour before they eat. Before they eat. You don't want to do it right away, or 2 hours after they eat. It takes almost 2 hours for the stomach to digest everything and empty itself up. So physiotherapy, you lay them flat and you bang their back and then you break the mucus out. You fist, you do your fist, and then you just break all the mucus from their back. So it's like massaging their back. But if they eat and you do that, they aspirate and you worsen their respiratory problem. So you do that 1 hour before they eat and 2 hours after. That's how the stomach is completely empty, and that help with that. And then the other thing that help with their lungs, even though they lose sweat and they will dehydrated, you shouldn't prevent them from exercising. So encourage exercise. And I know when you go out and exercise, you see your lung basically clear up. It's like coughing, your nose is running. Yes, you opening your lung, all the breathing. So improve lung function. So this improved lung function. So don't let them stay at home because they know they're going to get dehydrated under the sun. They can still exercise, just a moderate exercise, so that they can improve their lung function. So this is very important. And then we got to take care of their stool. Their stool is incipated. So you got to give them some stool soft bowel regimen. Okay. Otherwise, they will be clogged up. And above all, they need the social support. These kids are underdeveloped. They have a lot of problems. So case manager need to help with taking care of them. The sad part of it is there's something called vas deferens. I don't need to go into it, but that's usually take sperm and help you. Basically, you go down into the urethra and you ejaculate. So it's the passage of semen. Okay, that's passage of semen. So vas deferens. It's a tube that take all the sperm from the testicles into the urethra and then it come out during ejaculation. Well, they don't have it. It's underdeveloped. So what do you think? Well, they cannot have semen out. So they cannot ejaculate. Therefore, they are sterile. They cannot have a baby. So that's bad. So that is the cystic fibrosis. So that's what you need to know. You expect a SATA question on the education, what they need, what the treatment, and then how to treat them is very important. And then we have intussusception. Good. So all this is your bowel. It's a telescope. You have one bowel fold on itself like that, the same bowel, and one go inside. And so there's blockage. Basically, the bowel twists on itself. It's like a telescope. So the bowel telescope on itself. So they're going to have a problem. You know, when you twisting something, when you twist the bowel, blood supply is cut. So there's no blood supply. If the bowel doesn't get blood supply, it's going to be ischemic. And if it's ischemic, it gives you pain. And this is the B sharp I talk about. So they have belly pain, but this kind of pain is a pain that is live, limb, eyesight. The eye pain is live. It's an ischemic pain. So you have to be sharp about these people pain. It's pain, but it's not just any other pain. It's a B sharp pain. So ischemic kind of pain. These are the pain that is a priority. So this is the patient you see. Priority pain, ischemic pain. So you have to do something about it. So Usually this occur like when the 6 years, under 6 years, so it never usually occur above that, but it can occur. Older people can have it. If they have it, you worry about tumor. But for your exams, if it's a pediatric, it's less than 6 years. Because of the way I told you, telescoping, ischemia, kind of pain, heavy ischemia, that means dead tissue giving you a pain, is always sudden onset. It will happen right away. If the pain is due to ischemia, it's always sudden. Ischemia means tissue is dying, there's less blood supply, it's going to be sudden onset or acute. And the classic pain in this one is crampy and colicky, okay, back and forth as the telescope back and forth on itself. Like every kid, like I told you, the other one, pyloric stenosis, they're skinny. You can feel this intussusception, and it look like sausage. So sausage-like mass. They like these buzzwords, but I don't think it's important. But you have to know in case there's a SATA question, it's a sausage-like mass that you can feel in the abdomen. And because the kid is having ischemia, anybody who has ischemia in the abdomen, peritonitis, B sharp, this is sepsis. If somebody have acute abdominal pain, the best way to relieve the pain is to take the pressure from the muscle in your belly. And people usually put themselves in the fetal position. So put yourself in the fetal position. It's the same thing what we call knee to chest position. That will take away the stress on the muscle of your abdomen, and that will ease the pain a little bit. So they draw their leg up to the abdomen. So in physically, when you look at them, they have their knee to the chest. Okay. The pain is so bad that you can't console them. So this is another classic buzzword, unconsolable. And kid, he will be crying nonstop because this is like ischemic pain. It's so bad, and it's so painful. It's colic. So you go on the bowel twists itself. He try to release itself again and go back again, back and forth. So it's intermittent, colicky pain, and then the kid will be there, will cry, then will stop, then he cried again. You can't console them no matter what you do. In your test, they will put certain words there. This, I don't know how important. They may use that word, currant jelly stool. How did it happen? Because of the ischemia, okay, tissue is dying. So when the tissue die, blood will be released, dark blood will be released into the dead tissue that is dying. They release their mucus into the gut, the bowel, the small bowel, and so or the intestines. And then when the stool will pass out. Your stool is very blood is cathetic, so it will become like laxative, and so it will pass out from this. They will have a bowel movement, and so when they have a bowel movement, you see mucus and blood in it. So both of them combined. This is what it means by carrying jelly stool. So if they give you a SATA question or a question and they don't write these buzzwords because they know everybody know this, they will write mucus, blood, stool mixed with blood and mucus. So you have a stool mixed with blood and mucus. So that's what it means, carrying jelly and stool. They're going to vomit because there's obstruction. And because it's in the small bowel, it's going to be vomit is bilious. So that one too has bile in it. Okay, so that's how you can distinguish between them. So those are the signs and symptoms, and those you should expect in a SATA question. So how do you treat it? So when a patient comes in, you got to make a diagnosis quickly. So you have something is twisting. If we put pressure through it, it will untwist it. So that's the treatment. You can put fluid in and then blast the pressure and then push the bowel to separate, or you can put air in it and do that. So there's a contrast enema or air enema, which is what we call pneumotic. So pneumo, you see, is your lung. Yeah, that's air enema. So this is what most people like. They don't like the contrast, putting fluid there for somebody who's already has obstruction. So this is, they put uh, just a plain air inside. They pump the air pressure in, or the other word they will put in your exams is pneumotic enema. And this is best because it can diagnose it. You can see it on the X-ray and it can treat it. You don't want to put fluid in somebody you think they have an obstruction. So we use the air or contrast enema. And this can untwist it and the patient will do better. And then we observe them for a couple of hours a day and then they go home. Most of them don't need surgery unless it doesn't resolve. So, of course, they have to be NPO. They will need an IV fluid. They don't need antibiotic. They don't need antibiotic. They will need some pain management. But then they need to get contrast enema, air enema to relieve the obstruction and treat it. So that is all you need to know about intussusception. The next one is necrotizing enterocolitis. It has a fancy name, but it's easy. So necrotizing, the same thing. Tissue dying. Necrotizing means necrotizing is dead tissue. Entero, small bowel. Litis, infection. So that means there's infection in the small bowel. So if this is the kid, this is small bowel, there's infection all over. So they have infection all over. So the bowel is dying. That's the necrosis. And the small bowel, and it's causing infection. So you basically made that diagnosis. How did that happen? Well, this happened in the kid, mostly premature baby. So premature. They get born and they are first feeding. So first feeding in a premature baby, their gut is not developed. And then when they feed them, the gut get mad and they have infection and the bowel start to die. And so they don't tolerate it. So they have like infection, so severe sepsis. So this is a form of sepsis. It's a B-sharp issue. And so because of the kid is premature, they're skinny, the abdominal wall is right there. You can see their intestines move. So the infection can come onto the skin. And so they have this classic finding, abdominal wall erythema. Watch out for that. That is your priority finding right there. Abdominal wall erythema. So the abdominal wall look like a bruises, but it's erythema. So you see erythema, bruises all over the abdominal wall near the umbilicus. That's the infection has transmitted itself to the abdominal wall. And what would you do with this patient? Well, you got to make them NPO. You got to give them IV fluid. They have sepsis. They have infection. You got to give them antibiotic. You cannot feed their gut. So you can't put food in the abdomen anymore because that's what makes the infection. So some of them will need TPN, nutrition. And the treatment is they need surgery. So usually the bowel will perforate after the necrosis, it will die. And then they will go to surgery and they get a colostomy, so stoma or ileostomy. So the treatment is ileostomy. Not all of them will perforate, those that perforate. So you watch them, you make them NPO. When you see this erythema of the abdominal wall, they don't eat anymore. You support them with fluid, you give them antibiotic, you give them nutrition, and you wait. If they perforate, then they go surgery. But the priority thing is to recognize that abdominal wall erythema is sepsis. So treat the sepsis before they perforate. And so that's the key the keyword for that. So when you get lab work, what do you think you should expect? Well, if I get the lab work based on the name, necrotizing enterocolitis, it's an infection, so white count is high. Suspected finding, they will have fever. It's expected finding. They will be lactergic. That's not good. That means they have severe sepsis. They will have erythema of the abdominal wall, severe sepsis. So these two is bad. So that is everything you need to know on necrotizing enterocolitis. They always call it NIC, but it has a fancy name. It's just a very simple infection of the gut in a premature babies. And the last one is imperforated anus. The same thing. This is the descending colon coming. You go to the sigmoid, and then this is the rectum. Well, but there is no hole anywhere. This is the anus. It's supposed to be here. So this is the rectum. But everything is closed. So this is like, that's you call imperforated. So the anus, there's no hole there. So it's completely closed. So when you lift the baby, you examine them, you don't see anus there, nothing. There's no hole there. So what do you think? Well, the kid will be distended. He can poop. And would he pass meconium? No. No meconium in 24 hours. This one is within 24 hours. Hirschsprung, 24 to 48 hours. Pay attention to the numbers. This one, they don't pass meconium at all because there's no hole at all there. Okay. And then you have to call the doctor. So this will be a patient that you see, you examine in the NICU, and you don't see any anus. You call HCP immediately. So that is the summary of everything. Just one quick question, then we're done. As usual, we solve this SATA question. Which of the following assessment is consistent with the diagnosis? You have a 5-year-old admitted with the presumptive diagnosis of what? Hirschsprung. I show you how to write SATA. I need assessment. So expected finding. And I'm talking about intussusception. And you know you have a bowel telescoping on itself. They have colic, abdominal pain. They draw their leg to their chest, and they have sausage like abdominal mass, basically, and what you expect, the air contrast enema. So this is what you have. So one, non-bilious vomiting. This is wrong. When they vomit, it's bilious. Gradual onset of symptoms. This is ischemic pain, so it's acute onset. Postprandial emesis. This is talking about pyloric stenosis. Postprandial. It has nothing to do with that. Olive-shaped mass right of the umbilicus. This shape is sausage. Olive is pyloric stenosis. Wrong. BUN of 20. This is more consistent with pyloric stenosis, although these people will be dehydrated because they are not eating. But look at it. This is an acute problem. It's an acute abdominal pain. They don't have time to be dehydrated. So you got to think about it. Pyloric stenosis, they have time. The kid has been vomiting for a long time. As soon as he eat, he vomit. So they have time to develop BUN greater than 20. That's dehydration. These people doesn't. Intussusception is acute onset. They don't have time. So they are not that dehydrated. Prescription of mnemonic contrast enema. Yeah, this is the treatment. Then erythema of the abdominal wall. No, and that is necrotizing enterocolitis. So this is a typical one. I intentionally put it there Don't expect because he said a SATA, you get more than one. Well, you can get just one answer. They can trick you, and you don't have to choose everything. You got to look at your information. You see what I did. I need assessment. I need intussusception, and so I talk about what I should expect, and I go back and I eliminate them. So all that we have was this. So you don't have to choose everything. Once again, thank